I appreciate that. Thank you. Yes. So, all right. Should I go back? So it's in the recording. I think everyone's here, so I think hopefully we'll be good. But all right. So if you're watching this recording right now, I wasn't recording the first several slides before this, so make sure you go back and look. There we go. A little reminder. Okay. Yes. Thank you for making me aware of that. Okay. All right, so let's continue here with this first issue of the joint production of pleasure and illness. So to start off, let's remember, right, that we're assuming that people maximize utility. They're not maximizing health, right? So let's remember that first of all. And really one of the most popular or frequent ways of approaching consumption is sort of a lifetime consumption model, right? Looking at people's consumption over their lifetime, where they make decisions about consumption in various periods in their lifetime, right? So maybe it's a year or monthly or something like that. But the main thing there is that in that type of model, this lifetime consumption model, people can do things today that affect them in the future, and in particular, we are thinking about health outcomes in the future, right? And so, really, the question is why would people deliberately consume tobacco, alcohol, race cars, go bungee jumping, go skydiving, right? Why would people do this? It puts them at a great risk of having negative health outcomes, right? Well, the answer is pretty easy, right? Those things are fun. People enjoy doing those things, right? Despite the risks, right? So that's really what this issue is talking about, right? There's in many cases with a lot of consumption items, there's a joint production of both pleasure and illness, right? So, but people there's still a rationality to it, right? People do it because it's fun or it's pleasurable, right? Um, so that hopefully is not surprising, right? But these issues, are directly related in a lot of ways to addiction, right? Smoking and drinking, even skydiving, right, can be addictive because of the adrenaline rush, right? The adrenaline kick is addictive for a lot of people. Um, Gambling might be another example of something that's addictive, right? And so the main question here is there a way that economists can help us understand addiction? And the answer is yes, of course. Economists can handle lots of stuff. And so this was actually an endeavor embarked upon by Becker, Grossman, and Murphy in 1991, and they developed a model of rational addiction. Right, so we can still have our rationality assumption, right, and think about addiction at the same time. And so in their model, the results of the model tell us that people actually choose to become addicted so that they can enjoy the pleasure of consumption. But the model also describes sort of an evolution of behavior that is predictable, right? Um, and so that's a pretty cool model. Could, especially so this is when economists and psychologists really started to sort of butt heads. They had been disagreeing a lot prior to this, but this one really upset psychologists, right? Because they're like, no, addiction is irrational, it's harmful behavior, people shouldn't do it. And then along come these guys and they're like, no, addiction's totally rational. And psychologists just had a huge fit. So um, but their model is incredibly useful, and pretty cool. So some key features of the model, and this is probably the key feature, in fact, is that consumption that took place in the past affects the marginal utility of current and future consumption. Okay, so the idea is that, and I'll just use my favorite example, Oreos. The idea is that, you know, imagine that I've never had an Oreo before, right? And someone's like, "Hey, you want an Oreo?" And I'm like, "Yeah, of course. A cookie? Sure, I'll try an Oreo." And I eat that first Oreo, right? I'm like, "Damn, this thing's good. This is a really good cookie." Um, Not only am I enjoying it today, right? But this model of addiction says that now in the future, I will enjoy Oreos even more because of my experience with them today, right? That's basically the idea. Um, and so it'd be the same thing with like cigarettes or gambling or anything like that, right? I have that first cigarette today, and now all future cigarettes that I have, I will enjoy even more because of my consumption today. And that's because of the addictive nature, right? It's due to the addictive nature of cigarettes or Oreos, right? But because of that, it means that my consumption of Oreos today will increase my demand for them in the future. That's one implication of this effect. Another implication is that higher prices in the past cause lower demand in the current period or in the future. And that's a pretty straightforward idea. It follows directly from this first key feature that we talked about, right? Because if prices are higher, the law of demand says that I consume less. And if I consume less, then my marginal utility in the future doesn't go up as much. And so my demand is less in the future or today, right? In other words, consumption in the past, present, and future are complements, right? That's basically the same thing, right? Higher prices, lower demand, right? That's a complement. And so basically, this model is saying that addictive consumption um, are complements. Now, another interesting and strong implication of the model is that long run elasticities are larger in magnitude than short run elasticities. And that turns out to be empirically supported, right? What we see in the data is that yes, that's true. In the long run, people are more flexible than in the short run, particularly in this case with addictive substances. And I don't know if that's like mind-boggling, because that tends to be the pattern with almost anything, right? If you have a longer period of time to sort of adjust to things, then you will be more elastic in the long run than in the short run. But it turns out to be an implication of this model as well. All right, so just to look at some examples, these are from empirical studies, various empirical studies. So for tobacco, one study found that the short run elasticity was negative zero point 0.4, while the long run elasticity was 0.7. So both of these are within the inelastic realm, right, between 0 and 1, but the long run is more elastic than in the short run, right? Gambling at the racetrack, so gambling on horse races, very similar result, short run elasticity of negative 0.3 and a long run elasticity of negative 0.7. There was a study on heavy drinking where they didn't actually explicitly calculate the elasticities, but they did conclude that a change in the excise tax for alcoholic beverages have larger proportional effects on liver cirrhosis, which is sort of the long run effect of drinking, than on immediate consumption. So again, we're seeing that there's a more elastic impact in the long run as measured by the liver cirrhosis deaths compared to the short run effects of immediate consumption. And cocaine, pretty much the same results. This study calculated the elasticity of a temporary price increase, as well as short run and long run responses to permanent price changes. And as you can see, the pattern is the same as what we've seen before, right? Shorter term, shorter run elasticities are smaller compared to longer run elasticities. I think maybe one interesting thing here too is that the long run elasticity is actually elastic. And so that's interesting, especially given that cocaine is so addictive. So this might be indicating some sort of desire to like kick the habit, so to speak. So, all right, so that's addiction. Any questions so far? Good. Okay. Let's see here. All right, so the last one has to do with incomplete information. Um, so it might not be that the substance or the consumption is addictive. Um, it might just be that there's a lack of information, right? Information has a direct effect on demand through people's preferences. Um, and so an uninformed consumer's demand will always be different from someone who is fully informed, right? It'll shift. It doesn't really, we don't really know what direction without more information, but it could be higher or it could be lower, given the lack of information. And this type of incomplete information can appear in several ways. It could be that the person may not know the information, right? So this is kind of the most straightforward one. They simply don't know. And if someone were to inform them, they would change their behavior, right? Pretty straightforward. So that's kind of the simplest one, the one that you probably were already thinking of. But it could be that the person knows, they simply ignore it. They choose to ignore the information. And this is what is called myopic addiction, as opposed to rational addiction. And there's a third possibility. It could be that the negative consequences are so far in the future that they are basically ignored in current consumption. So this is kind of like the second one, but not really. It's the fact that it's being ignored has to do with the fact that the consequences are very far off in the future. So it's really sort of um, it's sort of irrational to consider them, um, in a sense, right? You could consider the future consequences, but it might be difficult in terms of like mental energy, right? Or whatever. Or it's just like, I don't know. I don't know if any of you have had a class where you talk about time preferences, but that's a big thing going on here is time preferences, right? How patient or impatient is a person, right? Um, if someone's very patient, then they typically think about the future more than someone who's very impatient. The impatient person thinks more about the current moment, right? Um, so this third one's really about time preferences and what's called the discount rate. And so a classic example of this information issue comes from smoking, information about smoking. Okay. So in 1965, the US Surgeon General published um, a report on the adverse consequences of tobacco use. And as a result of that, there have been basically decades of steady decline in smoking rates. So 40% of the population smoked cigarettes in 1965. That has been cut in half by the year 2010. And there's another aspect of this that is important to think about, and that's education. Okay. Because people with higher educations basically are better able to understand and process information about risks. So if we looked at a little bit more closely at this trend in terms of education, it turns out that those with lowest levels of education, the rates of smoking among that group of people has basically stayed flat. So this information given by the US Surgeon General in 1965 basically did not change people's behavior that had low levels of education. There's been almost no change in their behavior. But among people with higher levels of education, the decline has happened more rapidly. So the higher the educational attainment that we look at, the faster that decline in smoking rates has been. Um, so pretty good evidence that education plays an important role here with regard to information. Not surprisingly, hopefully. Okay, any questions so far? So that's this issue of uh, the demand for illness, right? So again, it could come from the fact that things that we like, things that are pleasurable, also sometimes decrease our health. A lot of times, these things are addictive, and if it's not one of those things, then it could just be a matter of information, right? So all three of those things are sort of contributing to the demand for illness, right? Okay. Next, we're going to look at the demand for quality. Okay, so we discussed sort of from a theoretical basis the demand for quality, and we talked about sort of two facets of quality, right? There's the we can think about quality in terms of how well the doctor can transform a procedure or a treatment into good health. And then we also talked about sort of a different way to measure quality, and that's in terms of amenities, right? Does the doctor have a nice office with a nice waiting room that has televisions and magazines to read, and the environment is comfortable and those sorts of things, right? So different ways of thinking about quality. Um, I think probably the more important one is the first one, right? How good is the doctor at transforming care into good health? Um, and one way that that can be achieved is through extra training, right? Particularly with specialists. So extra training as a specialist, we from a theoretical standpoint, we would expect that to basically increase the doctor's quality and therefore lead to a higher willingness to pay for their services compared to, say, someone who's not a specialist, right? And as it turns out, there is some evidence on this issue from the RAND health insurance study. There is some weak evidence, and it's mainly weak because it's aggregate. It's a form of aggregate data. But it was found that the price for an office visit to an internist, which is someone that practices or specializes in internal medicine, the price for them was 10 to 20% higher than a general practitioner who is not a specialist in any way, right? But again, this was kind of weak in the sense that it's aggregate data, right? We don't have much details. It's a conglomerate of information, so relatively weak. But there was another area in which there was some stronger evidence, and it was found. And this is still the RAND health insurance study. Um, they found that people with more generous insurance plans chose specialists more frequently than those patients that had higher deductibles or higher co-insurance. Um, but again, these findings should not be that surprising. Um, Now there were some issues with the second, the stronger evidence. Some economists went back and looked at it more closely, and let's see, they found. Let me read it to you here. They found some issue. What was it? Oh, okay. So a separate later study found that choice of provider specialization was not significantly related to insurance plans, and it doesn't give any more detail than that. But I guess the stronger evidence didn't turn out to be that strong when it was reviewed later, about a decade later. But nevertheless, like even though it's strong, even though the evidence isn't that strong, it is pointing in the same direction as theory would predict, right? So I don't know, take it with a grain of salt, I guess. There were some other issues potentially related to this study. So some people in the study may have been reluctant to switch from their prior doctors, but others did switch. Um, so that kind of complicates the issue here. Um, and part of that is related to the short duration of the study. Remember, it was only 3 or 5 years that this study went on. So that may have been why some people simply didn't switch. They're like, oh, it's only going to be pretty, it's a pretty short time period. It's pretty much temporary. So I'll stick with my current doctor, even though I might be able to see a better doctor with this new coverage from the study. But the group that did decide to switch sort of provides us with an interesting group to look at, right? Um, they are they're it's useful to look at that which to look at the effects of the insurance on their demand and give us some insight into perhaps why they did switch and maybe its relation to the quality of the doctor in terms of their specialty, right? Um, but even though this did provide sort of an opportunity of a somewhat natural experiment within a real experiment, um, the effects of plan generosity on provider choice were still pretty weak. Although there was one example of where the results were very statistically significant, and that was among children. And so, in families with children or households with children, those that had the full coverage were 10 to 20% more likely to see a specialist instead of a general practitioner. Um, which I think, isn't that surprising, right? Children, right? We're very sensitive. Parents are typically very sensitive about their children and very protective. So it makes sense that those that had full coverage would be like, all right, I'm taking my kid to the best doctor I can find, right? So that's not surprising, but um, it kind of does bring up sort of an issue here, and that's that we actually don't have a lot of information on this relationship between price or insurance coverage and quality, right? Um, there's really not a lot of strong evidence out there. There have been some more recent studies, okay, because all of these other ones we've been talking about happened like in the 70s and 80s. What about more recent stuff? Well, there was a more recent study. I don't know how to say this economist name, Macy Juski. I don't know. I'm probably butchering that, but Macy Juski et al. From 2011. They used a natural experiment, so not as statistically reliable as the RAND health insurance study, right? Of course, that was a randomized control trial, so it's a well-designed experiment. Natural experiments, they're not designed deliberately, they happen naturally, they're naturally occurring, so they're not as strong. They don't give us as strong results, but they're still better than nothing, okay? They still have elements of a random control trial. And so this group of researchers used a natural experiment where Veterans Affairs medical centers increased co-payments. And what they found was that when there was a $35 increase in co-payment, it actually had no effect on the likelihood of seeking specialty care, but it did cause a decrease in specialty expenditures over time. So sort of a mixed bag of results, right? So it didn't change the probability that a patient looked for a specialist, but it did cause patients to reduce their spending with specialists slowly over time. So a bit of mixed evidence there. So like I said earlier, even today, right? And keep in mind this version of the textbook was written, I think in 2013 or 2014. So I'm sure there have been newer, more recent studies that might give us a little bit more insight into this issue. But even as late as 2012, 2013, there's still not a lot known empirically about the demand for quality. Um, and also keep in mind that basically all of these studies are looking at the first facet of quality, right? How good is the doctor in transforming medical care into health outcomes? Um, we really didn't have any studies that looked at the demand for amenities, right? Again, I think it's mainly because amenities, while they're nice, I'm not sure that we really care about them because amenities don't improve health, or at least I wouldn't imagine that they improve health. Maybe there's some small effect in there, but um, having a TV in the doctor's office is not that important for someone's health, right? So if if any of you decide to go into being a health economist, here is a field or a branch of study that needs work. Okay, this is a good area of research. We need more information in this realm. Um, but at least what we can take away is that intuition and theory tells us that more generous insurance should lead to higher quality providers and a higher willingness to pay for them. But like I said, direct studies on these issues are hard to find. All right, any questions so far? Okay, let's continue then. All right, so now we're going to look at some other studies on the demand for medical care. Um, and as we've seen, so far, as well as in the last chapter, looking at the theory, demand should both theoretically and empirically vary with numerous variables, including income, education, quality of care, institutional settings might be another one, and there's a bunch of other ones that are unnamed, but gender, uh, age, right, all of those. Um, and so, of course, it would be useful to us to know how to find data that can produce information on consumer demand and allow us to investigate these variables and how they affect demand. Right. So that's basically what we're going to talk about next is what are the ways that we can find the data, right? Where can we find the data for these things, right? So we're going to look at some examples. So the first example is yet another example of a natural experiment. And these first few natural experiments that we're going to look at were specifically, the studies looking at them were investigating the demand for physician care. The first one was Skitovsky and Snyder, 1972. And they noticed that there was an opportunity for a natural experiment at the Stanford University, where in 1967, Stanford University changed its employees' insurance coverage, mainly because of cost concerns. Okay, so um, employees of Stanford University had been receiving full coverage, zero co-insurance, right? And in 1967, they changed that co-insurance rate from 0 to 25%. Okay, so very, very similar to the Rand health insurance study, right? Although this was not a controlled trial, right? This was just a policy change at Stanford University, and so while it's similar, we kind of have to look at it differently, right? We don't have different groups with different co-insurance rates like the health insurance study. What we have is we have the entire population of Stanford University employees before the change and after the change. Okay, so those are the two groups, but it's basically the same people in both groups, right? So that's a pretty strong, significant difference there. And so what we really have is sort of a threshold model. So we're looking at medical care use before 1966, before the change, Or yeah, okay. So let me not confuse you here. Medical care use before the change, which was in 1966, and care use after the change in the year 1968. Okay. And hopefully, perhaps not surprisingly, the results were very resemblant of what was found nearly a decade later in the Rand health insurance study. The number of doctor visits, for example, fell by a quarter, and the number of diagnostic test use fell from by 10 to 20%. Not surprising, right? Price goes up, quantity goes down. Law of demand, right? Not surprising. But we do have to keep in mind that this was a natural experiment. It was not a control trial. And so there could have been something else that changed at the same time that led to the changes in behavior. So we need to make sure that we think about that. And so just for the sake of example, it could have been that there was a flu epidemic in 1966, or it could have been that there was a flu epidemic in 1968. And in either of these cases, that would have wildly biased the results, right? So let's first think about if there was a flu epidemic in 1966. Well, that would drastically increase the medical care use prior to the change. And then the change happens, the epidemic is gone. We look at what happens in 1968 and we say, oh yeah, there's way less use in 1968 than 1966. But part of the reason there was so much use in 1966 is because there was a flu epidemic. So it's sort of, this scenario would overstate the results, right? The results would seem bigger than they actually are, right? Because we're trying to look at just the change in health insurance coverage, but there was something else going on at the same time. And then if we think about the opposite case where there's an epidemic in 1968, well, then that's going to understate the results because there's going to be a certain level of medical care use in normal times. Then there's the insurance change accompanied by a flu epidemic. And so there's more use in 1968 than there would be under normal times. And so the results of the change are actually diminished, right? So we have to think about this since it's a natural experiment. And of course, the authors did think about it, and they concluded that there didn't seem to be anything substantial that happened that would have caused this change other than the change in insurance. So they were pretty confident that their results were sound. But it is something we have to be careful about anytime we use data from a natural experiment. Okay. Now, taking a second to sort of go back to the idea of cross elasticity and complements and substitutes, we saw earlier in the RAND study that there was complementarity between ambulatory care and hospital care, right? We saw that there was complementarity going on there. A more recent study looked at the cross-price elasticity between medical care use and prescription drug care use. And so this was a study conducted by Gaynor, Lee, and Voigt in 2007, so relatively recently. And they found that the own price elasticity of prescription drugs were 0.6, negative 0.6 in the short run, negative 0.8 in the long run. So nothing too surprising there. Pretty similar results to what we've seen in terms of elasticities for all kinds of medical care use. So pretty much everything we've seen is in the 0 to 1 region, right? So inelastic. And then the same result in terms of short run versus long run, elasticities are bigger in the long run, right? People are more flexible in the long run. So nothing surprising there. But just to be clear, this is not yet a cross-price elasticity. This is a normal price elasticity of demand. But now we're looking at the cross-price elasticities. And so they found that physician ambulatory care and prescription drugs were substitutes. So they had a positive price elasticity, cross-price elasticity, right? So that as the price of one went up, the demand for the other went up, right? So they move in the same direction. That's why the elasticities are positive. They're substitutes. Although the response is pretty small, right? These numbers are pretty close to zero. So very, very small responses to price changes. But they do seem to be substitutes, which I think makes sense, right? If you're on prescription drugs, the whole point of prescription drug use is to prevent illness. And if you're preventing illness, then you don't need to go to a doctor, right? So that seems like an intuitive result. Another study a few years later by Phelps, Beisman, and Gomez Ray et al. They found similar results. They found that the use of a drug that prevents angina attacks reduced overall medical care expenditures by 13 to 17%. Okay, so same result, right? Um, although they didn't express it for whatever reason in direct terms of an elasticity, but this is basically, if these things are substitutes, then this is the type of result we should see, right? So although it's not expressed in the elasticity, um, the fact that they are substitutes would result in this finding, right? Now, all of these studies so far basically they were basically cross-sectional studies, um, but we might be interested in looking at data over time, right? So a time series information perspective, right? And this was actually an opportunity within the British National Health Service, the BNHS. So over the span of 15 years, the British National Health Service made changes to the prices that it charged for prescription drugs on numerous occasions over a 15-year span. And Phelps and Newhouse took this data again as a natural experiment. So this is another example of a natural experiment. They took the data from this natural experiment and they estimated that the effect of out-of-pocket payments on total drug use. And they found that drug use was 15% higher under full coverage than under a 25% co-insurance rate. So again, same, well, no, this is not cross price anymore. So this is just the demand for drugs, right? So we're no longer thinking about cross price elasticity. This is just the demand for drugs. So nothing too surprising here, though, right? Simply more evidence supporting the law of demand, right? When price goes down, use quantity goes up, right? And there were other studies that basically closely matched this information, this result. So there was a study using data from Mississippi, Medicaid use by Smith and Garner, and another study using data from Windsor, Ontario, where they basically found the same relationship between price and the quantity of drugs used. Okay. Any questions so far about that? Okay. All right. Some more natural experiments, this time looking more closely at the role of time in demand for care. So there was one study where there was a major university that moved the location of its student health services center. And it importantly, it was moved further away. So at its original location, the travel time for students averaged from 5 to 10 minutes. The new location was about 20 minutes away. Okay, so an implicit change in the cost of time, right? More time. And what they found was that visits fell by 1/3 after the location was changed to the further location. And they were even able to estimate arc elasticities So they estimated the arc elasticity of student health service use with respect to time, and they determined that it was in the range of 0.25 to zero point 0.5, negative 0.25 to negative zero point 0.5, depending on whether they used 5 minutes or 10 minutes as the original travel time. Okay. Um, and again, not surprising. You increase the cost, this time in terms of time, right? Instead of price, it's time, but still a cost. You increase the cost, quantity goes down. Not surprising. It's the law of demand, right? But a pretty interesting, natural experiment. Now, again, we have to keep in mind there could have been something else that changed, right? There could have been something else concurrently that changed that led to this change in behavior. But again, the authors felt like there was nothing that they could determine that was going on simultaneously as this change in location. So they were pretty confident in their results. Another thing that's interesting that we care about is going to be the interaction of some of these things. And so here we're thinking about the interaction of severity of illness with demand, right? So how do these things coincide with each other when they move together? So Magid et al. 1997 looked at the effect of copayments on seeking medical care after a heart attack. Okay, so a pretty severe illness, heart attack. And one thing that they did was they looked at the time that it took for patients to travel. And um, they found that there was basically no difference in the time to arrival for those with no copayments as opposed to those with positive copayments. So there shouldn't be any difference based on differences in time, since basically all of these patients had the same time to arrival. And what they found was that there was no observable difference in use given copayments. And this probably makes sense. This is a pretty severe illness, right? We're talking about heart attack, pretty severe. Um, and so the fact that some people had moderate copayments in the range of $25 to $100 basically had no effect on use, which shouldn't be surprising. Now, if this was like a common cold and you're talking about full coverage compared to a $25 copay or a $75 copay, yeah, we would expect to see a huge difference, right? People with $75 copay are not going to go to the doctor for a common cold, but people with full coverage might. Um, so yeah, we would expect a difference there. But given the severity of a heart attack, a $75 copay shouldn't make that much of a difference, right? And that's basically what they found. Another study in this realm was Wedig 1998, and they found that, they found that those with fair or poor health had elasticities that were half the magnitude of those in good or excellent health. So again, those that are more sick are less flexible. So a related finding, right? Not, I wouldn't say it's identical or necessarily the same in any way, but it's similar, right? People with more severe illnesses are less flexible. Okay, there's also the interaction of time and the demand for care. And again, this was another natural experiment, and this had to do with travel time in Palo Alto, California. And this is again from the Skitovsky Snyder research paper. Um, and so they had this nice feature in their data where they actually coded the patient's home location, so they knew the distance. You could basically impute or calculate the distance that the patient had to travel to this Palo Alto clinic, and they found that the theory was supported. Those who lived further away used less care. So again, not surprising, right? It's just the law of demand. No big deal. And again, natural experiments. So we have to keep in mind there could be something else going on. It could be that some of the effect could have been that patients who were further away decided to see doctors who were closer to them. Um, but a nice aspect of this study was that the insurance plan that these people were under only covered visits to the Palo Alto clinic. And so if they did choose to see someone closer to them, they would have actually explicitly had to pay more. And so um, the result is pretty much still the same because of that fact. So another study, Kofi 1983, looked very, very carefully at this interaction. So this was actually the specific purpose of this paper, whereas the earlier ones, they were looking at a lot of different things. It just so happened that they could look at the time issue. But this paper looks specifically at the interaction of time and quality of care actually in this one. So not just the demand for healthcare, but the demand for quality. And she looked at the use of female medical services like gynecologist visits. And what she found was that use did not vary much with time costs. So this is opposite to what we've seen so far, right? So in pretty much all the other studies we've seen so far, when the cost of time increased, the quantity of use decreased. So she didn't find that. She actually found that there wasn't a statistically significant difference. But what she did find was pretty interesting. She did find that the choice of provider type was sensitive to time costs. In particular, the choice for these women that she was investigating was they could either go to a health clinic or a private provider. And she found that when the cost of going to the public clinic was high, travel cost was high going to the public clinic, that people often chose to go to a private, uh, um, which of course has to do with the quality, right? So I guess there's kind of an underlying assumption here, and that's that the public clinic has a lower quality of doctors than a private clinic. But if that assumption is sound, then we have an idea here of how time, the cost of time, can affect or interact with quality, right? And it seems like when time is a significant cost, people might opt to spend a little bit more money, not only to avoid the costs of time, of travel time, but also to just go see a better doctor, right? So that seems to be an important determinant here. Okay, so at this point, there's like an entire section in your book on. Let me see what it says. Okay, so there's an entire section on basically applications and extensions of theory, and the first subsection in that section is about welfare losses and how it relates to medical practice variations. It's a pretty complicated section, so I've decided that we're not going to cover that. But if you're interested, I encourage you to go over it anyway. But for the sake of time, I'm going to skip it, and also for the sake of complexity. But in a nutshell, basically the idea is that when you have all this variation in doctors and how they approach medicine, they basically are going to make decisions that end up hurting the patient, right? Reducing their consumer surplus. And there's a pretty cool, if you look at figure 5.2 and read the paragraph before that, it gives a pretty good explanation of how that works. Basically, right, there's a demand curve for care, and then the doctor chooses some level of care given the cost of care. And if they don't choose the right level of care, then they're either going to underserve or overserve the patient, which leads to a welfare loss in both cases. Um, And so thinking about welfare loss in relation to the variations in care is a pretty interesting theoretical exercise. And the book also talks about some evidence regarding this issue. But again, it's a pretty complex section, and I would probably teach it in like a master's level class. But I'm going to go ahead and skip it, and it'll save us a little bit of time, so that we can kind of, you know, time is of the essence. So we're going to push through that. So don't worry about that section. But we are going to talk about deriving the right demand curve, quote unquote, right demand curve. Okay, so that's the next section after that section we skipped there. But it's still related to variation in practice. So we talked about this earlier, right? How, you know, we talked about the one study about Boston and New Haven and the wild differences there, the differences in care in different regions. And we talked about how that may be due to education or beliefs, lots of different things. But ultimately, regardless of where the variation is coming from, the fact that there is variation is basically implying that many doctors don't actually use medical interventions correctly. There's some amount of error, essentially, right? But there are actually formal methods of helping doctors make better decisions. And in fact, my dissertation advisor, this was an area of his research. He was jointly he was doing some joint research with a physician at Emory University, and they were developing basically a software that would take the patient's vital statistics and a number of other measurements of their health, and it would the input of that data would be then matched against a huge database of patients and their information, and the program would spit back to the doctor sort of the appropriate actions to take in terms of treatment and hospital discharge. And it would also give information on the probability that the patient would have to be readmitted to the hospital, and a number of other things. But it was basically a program to help doctors, assist doctors in making better decisions. And so these types of things exist. Now, unfortunately, it seems like some doctors are resistant to these things. They're like, oh, a piece of computer software can't know better than me. I went to school for 7 years. I shouldn't be condescending to doctors, but you know, some doctors are resistant to this type of technology for some reason. But the whole point of these pieces of technology is to help assist the doctor in making better decisions and essentially finding the best demand curve, right? The appropriate demand curve. And if you're curious about these types of technologies, the appendix to this chapter has a discussion on what's called medical decision theory. And so that's basically what we're talking about there. And part of medical decision theory involves the cost effectiveness ratios that we talked about earlier, right? So looking at the cost effectiveness, whether it's in quality adjusted life years or some other thing, you know, we saw the qualities and the dailies, right? Typically expressed in some terms, either in quality adjusted life years or disability adjusted life years. Now, what we really care about is, you know, we should be a little bit more technical. We really care about marginal cost effectiveness, right? If I'm a doctor and I give my patient a little bit extra care, what is the additional cost effectiveness of that care, right? And recent studies have shown that cost effectiveness ratios can be effectively used to guide the use of medical interventions. And again, this is basically what my professor, Dr. Cox, was working on with the Emory physician. They were ultimately looking at a cost effectiveness sort of approach. And Garber and Phelps in 1997, they had a pretty interesting study regarding cost effectiveness ratios. They found that there's sort of an optimal rule of thumb for cost effectiveness, and that it's basically twice the patient's annual income. And so, for example, a person that earned a $40,000 per year salary should select interventions that had cost effectiveness ratios of $80,000 per quality adjusted life year or less. Okay. Anything above that wouldn't really be cost effective. But it's related to the person's salary, because we're really thinking about their ability to be productive, right? If they're sick, then they can't earn that money. And that's kind of where the connection comes from, right? Is the connection from between health and productivity. Now, one thing we haven't really asked at this point is why do we have such variation in medical care practice? Is it that doctors disagree about the value of care to patients? Do they disagree about the probabilities of illness? And in a study kind of related to that question, it was found that there's some variation in diagnostic tests and treatment following those tests, and that there's a high correlation between those two variables. So doctors that have a high level of diagnostic test use also ultimately, consequently, have large degrees of treatment following those diagnostic tests. So that kind of led to another question: why do doctors use diagnostic tests differently? But what seems to be at least a large contributor to the variation is just a matter of beliefs, right? And so, since that seems to be the cause of the variation, what would help alleviate these issues is just more knowledge, right? So that doctors have better beliefs, more accurate beliefs, because that's really what seems to be the main issue here, is that doctors simply have different beliefs about the efficacy of use, when and how to use diagnostic tests, et cetera. And so really the answer to these problems is provide us with better information, right? Which has kind of been a theme throughout the last several sections that we talked about here. And so one thing that is becoming more prevalent are decision trees, which is kind of like a medical decision theory sort of application, right? Decision trees. So maybe you've seen a decision tree before, right? You kind of start at the top, and it's like, are you feeling sick? Yes or no? And then you follow the tree down, right? If yes, you are feeling sick, do you have stomach pains? Yes or no, right? That's a decision tree, right? And so these types of tools can help doctors make better decisions, reach better diagnosis. And ultimately, there's kind of four elements that are affecting the doctor's decision to treat. The first is the beliefs issue, right? What are their beliefs about the efficacy of treatment? The second issue is they're kind of still related to beliefs, but the probability of disease, right? What is the probability that this person has the illness that I think they might have given their symptoms? Then there's the cost of treatment. And then the last one kind of has to do with the doctor's interpretation of their patient's preferences, right? Because, the patient is going to describe to them as best they can what they would like in terms of an outcome. And then the doctor has to sort of interpret that and think about how they can use medical interventions to try to achieve what their patient wants to achieve, right? And of course, there are potential errors in all of these aspects, right? But in pretty much all cases, errors tend to lead to overtreatment rather than undertreatment, maybe out of precaution. But it could also be that it seems that doctors tend to ignore the cost aspect. And that's probably largely to do with the fact that insurance covers a lot of stuff. So doctors aren't thinking about the cost to patients, but that seems to be maybe the major reasons that overtreatment happens more than undertreatment. So, uh, so with that, we will wrap this chapter up. So to summarize, we saw that a lot of empirical studies, and they pretty much all tend to confirm that the law of demand is useful, right? The law, the role of price is important. We saw that the RAND health insurance study, the best results because it's a randomly controlled trial. And of course, the main finding there is that overall medical care is price inelastic. Towards the end of the chapter, we saw that demand theory illustrates the importance of medical practice variations, and that really probably the highest returns lie in providing doctors with better information, right? If we can just provide doctors with better information, that'll improve their beliefs about efficacy, about what their patients actually want and the patient's preferences, et cetera, right? So, all right, looks like we're out of time. Are there any last minute questions? Okay, cool. All right. Well, that's that. I will be getting the exam posted soon, and basically what I'm thinking is that I will give you guys 48 hours to work on it. So it'll be posted and available 48 hours before it's due. You can use your notes. You can use the book. Honestly, you can even talk to each other if you want. I just make sure that you're not copying and pasting each other's answers. Okay. So it's basically open book, open note, open discussion. You have 2 days to work on it, and it'll be due, I believe Saturday is the due date. So, and then I will also assign you some homework. I'll have to take, but I'll post the homework for this chapter, and it'll be due basically next Tuesday. And homework due tomorrow, right? So don't forget about homework for chapter 4, that's due tomorrow, and then chapter 5 homework, and that'll be due next Tuesday. Okay. Okay. Any questions before we go? All right. Sounds good. I'll see you guys on Wednesday. Good luck on your homework, and I'll see you in a couple days. Bye.